Good afternoon, everybody. I'm excited today. We're going to have a friend of mine from Canada that many of you know, Phil Walton. He is what I call the king of perio stories. So he has probably some of the best stories around step-by-step on gingival grafting, implants, immediate placement, provisionalization. Hello, everybody. Thanks for joining. Hi. So Phil should be coming on here soon, and we're gonna talk. I think it was 5 P's. It was Porsches, parenting, perio, provisionals. Oh, there was one more. I forgot what it was. Let's see. Let's add Phil in here.
Porsches, there was one that I was missing.
I'm in,
Phil,
dude.
hey man,
What's shaking?
what was the fifth P?
Oh,
Okay, Porsches, parenting, perio, provisionals, and pressure.
that's right.
That was
Well,
the
that's,
last one.
I mean, that is like your domain, so I thought we should
That's-
touch on that.
That's my thing.
Look at the grisliness going on over there, both
You like
facially
this?
and otherwise. I
Yeah,
love it.
this is extreme. It's getting extreme.
I love it.
Someone just commented on one of my pictures of volleyball and then said Wilson. So I'm getting to that castaway stage.
I love it.
Yeah.
I know that you're a former long hair man. We've discussed this in the past. I think
We
you're
have.
returning to your former place out of necessity. Unless you're going to start chopping your own hair with the mirror, it's going to be happening.
Yeah, this is the real me.
I love
This
it.
is the real me. Yeah. So why don't you introduce yourself for anybody who may not know you?
Yeah, I'm Phil Walton. I'm a periodontist, born and raised and practice in Toronto, Ontario, Canada. And like everyone else, I'm suffering from the COVID blues right now. You know, locked in, making the best of it. I think it's similar kind of state here as it is in Cali.
Yeah.
Haven't practiced. It'll be two weeks basically since they shut all of us down. I treated a couple emergencies maybe 2 weeks ago, and that was the extent of it. I have not. This will be the longest. I was saying to my wife, the longest that I probably haven't practiced dentistry since maybe like a long trip that we took to Japan, pre-child or honeymoon or dental school. Like this is actually going to get a little insane.
Yeah.
So,
and that's a lot coming from you because you do more cases than I think many people do in a month.
Yeah, I mean, I think we share a lot of similar things, but you're a slow dentist guy. I'm not like a rush dentist guy. I honestly, we've talked about this. I envy you. I think I would love to, I think I'd love to grow to that if I could.
Yeah.
Somewhere, I don't think it's necessity. It's just the practice that I'm part of. It's the way it's structured. It's the way that's been normal. I certainly don't think I like compromise on care. But we work quickly and we work efficiently.
Yeah.
But yeah, I mean, we will see a boatload of patients in a day and do a bunch of surgeries. So this is like a halt, to say the least, in terms of things. But I'm dealing with it better than I thought I would have.
That's
Maybe
good.
a little bit of ADHD starting to kick in lately. But otherwise, it's like, I know you're I see how much you travel. I'm just kind of getting into the speaking game.
Yeah.
This is like probably the longest you haven't been on a plane, you know, being somewhere. Your wife and child must be thrilled to have you around to a degree.
Yes, right.
As much
yeah.
as you are.
We already got some questions. One question is, how many full arches are you doing a week?
Yeah. So it really, like, you know, Instagram is this, I think, for personal and reality and in dentally can sometimes be a skewed image of what's really happening.
Yeah.
And everyone posts their busiest days and their best cases. I try to be pretty true to form of what's happening, but it varies. So I can certainly not do an arch in a week.
Yeah.
And there can be weeks where I'm doing multiple arches. So I would say that, and I don't know what people think a lot is. For people who dabble in it, they would know. But my clinic as a whole, we do hundreds of arches a year between like the 4 surgeons that are there. And I'll do probably a handful of arches a month. So a lot of people might think that's not a lot, but I think people who know and who do this stuff routinely, who aren't
I think that's a lot.
Fair bit. And with any implants, as you know, it kind of builds up over time in terms of
Right.
responsibility and long-term care that comes with it.
Yeah, that's true.
Yeah.
So I know you and I just met in, oh, I guess it's been a year now. In February of last year, we were at the Noble
Almost
Biocare,
exactly.
Noble Biocare KOL meeting. And like, I felt like we clicked very quickly. And I think that it's because we're kind of at the same stage, the same kind of time in our careers and also in our lives. So we both have
Yeah.
like young boys, wives, practices, homes. And so I felt like there's probably a lot of other people that are in the same stage as us,
For
right?
sure.
Still like knowing what we want to do. I mean, we know what we want to do, but still like getting to our peak, let's say, and also trying to have this balance of having our children and our wives, our spouses at home, and really doing what we love, what we're passionate about, which is dentistry. So I don't know. I guess I felt like I clicked with you very quickly. I felt like I had known you for a long time.
Yeah, I think that I agree with you on all. Maybe that should have been the sixth P is podium.
Yeah.
But I think I totally agree with you. I think actually, you're I think a couple of years younger than me. Are you 36?
I'm 30. I'll
37?
be 37 in a few days. Yeah.
Right. Okay. Well, happy early
Yeah.
birthday. Yeah. So I'm
Thank you.
38.
Hmm.
But I feel like I'm a little bit. You're certainly ahead of me in the speaking game, and I would look to you for questions and answers on that. This is really a new thing for me, and actually a little bit sadly, I'm over it now. But this spring was going to be a very kind of breakout time for me.
Yeah.
In terms of, I had a ton going on. Like every other weekend, I was going to be somewhere doing something, and that's obviously been scrapped. But nonetheless, it's like there's obviously bigger things. It's challenging. I don't know. You're ahead of me on this. How worthwhile, and I know that's a weird word to use, do you find this podium thing is? Because people talk about it from a financial perspective, from a personal gratification perspective. Like definitely get a high from being up there, and I love
Yeah.
the networking of it and the relationships like ours that I've kind of fostered. And
Hmm.
most people say that has to be a big piece because finally, as you know, there's highs and lows to it in terms of, especially at the beginning when you're trying to build your reputation, right? So
Yeah. Okay. So yeah, that's a good question. I think that it's hard to give an all-encompassing answer. For me, it's very important because I've gotten to a point where it financially makes more sense, and
yeah.
I absolutely love it. It's one of my favorite things to do is teach, interact, be with colleagues, travel. I think one of the main things, the reasons why I love it is that it forces me to be on top of my shit all the time. I have to
100%.
know all the articles. I have to know who the best speakers are, what they're saying, what their opinions are, read books. And that's why, like, when I'm looking to, let's say, have a procedure done, outside of dentistry, that's why I oftentimes will go to speakers because I know what they've gone through, and they oftentimes have to be at the front lines of technology or research. But I think at the beginning, for anybody who's getting into speaking, it doesn't make a lot of sense financially, and you have to be away from your family, which is the absolute worst part of it.
Mm-hmm.
But when you get to a certain point, I mean, I can make more money now lecturing than I can in dentistry. When you think about it per hour or per day. And for me, a big part of it that many of you guys know, my kind of mental health history of going through hard times, is that I wanted some time to be out of the office. I wanted some time to not have overhead, to not have stress. And the only stress I have when lecturing is being away from my family. I don't have to think about, am I going to get paid? I always get paid. I don't have to think about, like, am I going to get sued? It would be very rare that I could get sued lecturing unless I really did something bad.
Yeah.
So that's one of the other reasons why I do it too.
Yeah. I mean, and that's it. It was a huge draw for me. People talk about burnout, and you mentioned about being a busy guy. I don't know how long I can sustain what I'm doing. I'm kind of like doing it while the going is good sort of thing is always my mind. A physical labor aspect on it, and it's nice to change of pace for being.
Sorry.
No worries.
Sorry, go back.
Yeah, so
I missed what you were saying. You said you were a busy guy. Say that again.
Yeah, burnout. I was kind of referring to
Yeah.
burnout. And like for me, this is at least, I thought, another way to do something that I enjoy that's dentally related without the physical laborious aspect to it.
Totally. Yeah, that was a big part for me that I forgot to mention too, is I was having really extreme back pain when I was working like 6 days a week.
Right? I mean, every dentist, bad
Yeah.
neck, shoulder,
Yep.
etc.
And I was working for a DSO where I was doing all oral surgery, and I would take out like one time I did like 96 teeth in a day,
That'll
and
do it.
I got double tennis elbow in both of my elbows, and I couldn't eat. I had to eat like a dog, like put it on the table and eat off. And I was like, hold on, this is too much. So that was another reason why I wanted to shorten my clinical days a little more. Like you said, still do something dental related, something that I really loved. And I've kind of always been on stage my whole life. I was a professional dancer, as a professional musician, and so having
I love those
the ability.
I die for those old posts, by the way. Like,
there's a lot more coming. I just digitized all my old stuff, so there's a lot more coming.
I love
so let's talk about immediate placement and provisionals a little bit. I know that you do a lot of these. I also do a lot of these, and I know that a lot of people have questions about this. So what's kind of your, quick step by step?
Yeah. So one of the things that makes my situation's a little bit unique in that the practice that I work in is geared entirely towards same day implant dentistry. And what I mean by that is we have, like, in the corner of the place, it's like a full scale lab that was like built into the place. We don't happen to neighbor them. We were in a smaller facility. We've since moved. And so we have a full blown lab, and there's two labs actually. One is like our singles / like porcelain lab, and the other is actually like an arch lab. So it's just people working strictly on like the all-on-4 stuff. From a workflow standpoint, we actually lack digitally. We're trying to improve on that. I mean, that's something that you're way ahead of from our standpoint. I'm not against it. I think it's necessity. I think it's like, I think I used to be a surgeon who was like, this is art form. I'm trained. I'm the guy who kind of knows what I'm doing. You shouldn't do, like, I think that's key aspect foundationally. But anyway, so I guess with our situation, typically we'll see a patient. We now will scan them as opposed to taking like analog impressions, and we they have a temp shell that's made for them for a single case, or like a full denture that's made for them for a complete case. And when we talk about different versions of guided, so I'll have that shell with me during the surgery, extraction, implant placement, and then we use the shell. We pick up the shell using a temp sleeve, and we basically, it's a resin temp. It's made from a resin called Radica, and we just use flowable to kind of cure it in place. For every single surgery that we do, I have a lab technician over my shoulder for the duration of the procedure.
That's amazing.
Telling me if I'm deep enough, buccal enough, lingual enough, mesial enough, drop it down a couple of rotations, because they can envision even more. So I've now learned the emergence, etc. That was a big learning. That was a big change for me, because I was very surgically based in my residency, and it was like old school, right? Like, put the implant in, it osseointegrates. That's
figure it out
from a surgical standpoint. Leave it to the dentist. So I now have elevated myself surgically, because the accountability is right there in the room. If I don't do it, they won't tolerate it. So it's like, I have to have that kind of end in mind type of thought that we all discuss. So it then goes off to the lab, and honestly, depending on the lab tech that's working on it, anywhere from 15 to 30 minutes later, we have two operatories that are like mini labs between our surgical operatories. So they don't even have to go as far to get back to like the main lab to do the small adjustments in between. Because sometimes we'll insert it and be like the bone is hitting, or this contact is too tight. We even have one guy who actually keeps like an air compressor on his belt, and he'll literally just like do it. So it's like we've tried to make it the most efficient kind of for what we do. So that's why we can do. And you've met Susie Maxwell before. It's like,
awesome.
She's incredible, and a lot of people in the States don't know what a denture is.
Yeah.
but she's fantastic. And we have her and many others like her who are working behind the scenes, kind of whittling away at the full arches.
So while you have the provisional being made, do you just have a healing abutment in?
Yeah, I'll just stick a healing abutment on.
Yep.
Typically I'm usually grafting around the site anyways, so I
Yeah.
kind of use that or a driver. And then the patient just sits there and we sit them up and they just chill for the period of time.
Yeah.
And then I just honestly sometimes be seeing another patient in the interim and then just returning to insert it. It could take a few tries. Other times it just goes in like a glove and that's the end of it. We do a quick occlusal adjustment.
Sure.
Take an x-ray, make sure it's seated. And then we normally see them 2 months later, 4 months. And at 4 months, then we'll, depending on the tissue state, and if we want to change thing with conditioning with the temp already there, then we'll move to the final.
So you brought up a really good point that I think I'm happy to hear that dentistry in general is moving towards, and that is surgeons understanding what restorative doctors are going through, and restorative doctors on the other side understanding what surgeons are going through, and bringing those two things together. I think that this is something that I've been like trying to harp on forever, because I do both sides, so it's much easier for me to, communicate with myself. But I hear it from both sides. I hear the restorative doctor saying, the damn surgeon put the implant too shallow or too buccal or too medial or whatever. And then I hear it from the other side, the surgeon saying like, I had this perfectly placed implant, and then they put, they put like some restorative material subgingivally, and now I have all this bone loss, and everybody's complaining, or they overloaded it or whatever it is. And so that's really cool how you were saying like you have a lab technician too, because that's the third part that I think most people don't get is the lab technician input early. And early in my career, I didn't do that. And I had cases where I would, me and the surgeon, if I was working with a surgeon at the time, would be okay with it. And then we send it to the lab technician and they'd say, well, the zirconia is going to be too thin here. It's going to fracture.
There's
or
limitations from a material standpoint
that we don't think of. Or like the screw, if you're doing a multi-unit case, and then you have a screw on top of that, you have so much restorative space. Now we don't have space to put a composite plug on top or whatever it is.
Yeah.
All these little things that you need to have the whole team on board. And the best way to do this is through the digital workflow, unless you have like what you have, someone like looking over your shoulder.
Yeah, so we have obviously a good and we like when I lecture to people, and one of the common questions I get is, how do I do this from a chair side fashion?
Yeah.
And I don't mean to be discouraging, but it is hard, especially with temporization, because there's so many facets. Like people say, do I temporize everything? I mean, we temporize a lot, but not everything.
Yeah. Mm-hmm.
But there's a lot of intricacies, as you know, to make it work. So for instance, if you do not have that kind of subgingival portion of that temporary, smooth as a baby's bottom, as on other elements, it can cause disaster, right?
Yeah.
So, and I think you can go at something with soft flex discs a lot and glaze it, but you better really be diligent chair side if you're going to try doing that like properly. Otherwise, you're going to be the person who comes to my lectures and says, I tried doing this before and the tissues got really inflamed. I got abscesses and I lost bone. And it's like, well, that's because we weren't doing it properly, right? So it's not as, I think another difficult part of Instagram is like, here's before, here's after, here's the beautiful outcome, right? Like there's a lot of steps that take place.
You temporize everything.
Honestly,
I've gotten to the point where I kind of temporize everything too.
We try to.
Yeah.
We're bad. We're actually, one of the greatest challenges is because that's how we've built the reputation from a referral base in the city. There's an expectation.
People expect that.
I've had I don't want to say unprofessional, but I've had referring doctors who will call me after I decide against temporizing something because I didn't want to place the implant. Maybe I was too close to the inferior alveolar nerve, the sinus, legitimate reasons. And Blake is checking in. He loves this backdrop. It's his favorite.
Matches my underwear.
Yeah, exactly.
Bruno. Oh, nice.
But
Andy's here too. Wow, so many good friends.
Yeah, I love it. So it's hard delivering it, and I can tell you that we have this is like the truth factor, and in it is that we have more failures. I mean, I have more failures because of it, because we know we're pushing the envelope, but we also have the infrastructure to handle those failures. So a patient's temp will become loose or a problem will happen, and they come in and we can handle it. So there is a bit of a double-edged sword to being as aggressive as we are. I don't think we're like cowboys because we know
No.
what we're doing. We will commonly not joke but discuss between the surgeons that we knew the implant was going to fail. Like we pushed it. It was like the patient wanted it. They were demanding. We got 10 Newton centimeters and went for it. Like it was like it wasn't that when the stars align. Yes, we still have failures, but it's normally if you do things properly, it's out of occlusion, a decently compliant patient, you properly have this done, it works. And it's crazy to me that there are these camps out there of people who are like immediate temporization is bullshit, which is just, it's crazy. It's so evidence-based, it's out of control, right?
Yeah, it's true. You know, and you bring up a good point. It's like, you can do everything gold standard, research-based, all this stuff, and things can still fail.
Oh,
and
of course.
This is what I talk about all the time is that like, what I tell my patients too, and I forget who told me this, I wish I could give them credit, but they said, you know, I can do everything to the highest standard, right? Yeah. When you leave that day, everything else is kind of up to you, right? So are you following my directions? Are you eating the right things? Are you, using what you're supposed to do?
I say it to my patients all the time. And this guy, I don't know if, Kyle, I don't know if you follow Mohammed Bassam or not. He's ridiculous. He's in Kuwait. His work is
nice.
He's amazing.
I'm not sure if I do.
You need to. He's asking, have you had screw loosening with immediate temporization? So
I have.
Yeah, of course it happens. And again,
on high stability cases.
Yeah. So we did something different. So you know that I work with Nobel. I also work with Strawman.
Yeah.
When we're using Nobel, we actually use for temporization. We don't use their metal temporary copings. Okay. And the thought process was, and please pipe in because you're like as educated as anyone on this. The mentality was we were using actually a nylon sleeve, and it's actually a lab piece of equipment, a lab component. So we were kind of using off market, if you will.
Yeah.
But our thought process was that is not a rigidly attached component. And because most of our patients don't comply and will chew and will forget, if we want something to loosen, we want the temporary to loosen. And the thought was that the breakage of the idea would be that it would break at the junction of this component, which was plastic and or nylon, or it's PEEK actually, and with the collar of the implant. Or when we put the rigid ones on, if they bite on it, because it's actually like an internal connection, they're going to transmit those forces to the implant proper, to the fixture, and then you could see the implant fail. So we would rather the patient come in saying my temp is loose before they just keep hammering at it, and then the implant is loose itself. That was our mindset.
It's like having a fail-safe. You know, some of our team at USC, we published articles, gosh, a long time ago, I think 10 years ago, talking about adding in a kind of non-rigid material like milled composite to recreate a periodontal ligament on implants. And so this is one of the reasons why on single teeth, oftentimes now I don't do full contour zirconia, is I'll have like an Emax on top of it so that we get a little bit of a dampening behavior. Sure. So, but it's the same idea, it's this fail safe. And I think with that idea, the only thing where you may get something negative is if it doesn't engage the conical connection, does it?
So it does.
PEEK one?
So you can actually, the PEEK ones do engage, and they come in engaging and non-engaging. So if you're doing a bridge, for instance, you can have it as non-engaging, but it becomes engaging. Yeah, so it does engage.
Yeah, then I don't see anything wrong with that.
It's
because you have PEEK. If it was plastic, I would say no, but if it's PEEK specifically, we know we can get epithelial attachment to PEEK. So yeah, I think that's a great idea.
Yeah, and the resin goes, right down basically to the end of it. So, but again, I don't know if that's the answer or anything, or whether it really helps us a ton or not. But that was our mentality. But sure, anything gets screw loosening. We get screw loosening in full arch probably most commonly if we cut corners and you don't seat something passively. I mean, right? And then you see that later. So yeah.
And then how involved are you with the restoration in your camp? Do you have like input on materials or anything like that?
I don't. So, I'm like becoming more educated on that side of things, but I
Yeah.
think I'm still like, as a specialist, I actually just view myself like I'm very within my scope type of specialist. Like
Yeah.
I defer to you. You know what I mean?
Yeah.
Like I say that about every general dentist that I work with. Like
That makes me so uncomfortable to think about that.
Well, I just do it so I can blame you guys, right? I said they're the experts.
Well, it's true.
No,
But when
no,
you find a
because,
good team,
well, that's a
then
different story, right?
something
So,
you can trust. And I think that's the hard thing that many of my specialist friends have a problem with is, you know, they get referrals from, let's say, 20 different doctors, and they
yeah.
know that really they can trust 5 of them,
So I'll tell you something interesting about
which is scary.
So this is an interesting thing about the way our practice is structured and how we grew. Because we have a lab, we also have general dentists and prosthodontists working there.
Yeah.
We have 2 streams of referrals for our patients. So if a doctor who is inexperienced in implant dentistry would like us, we will take it as far down the path as possible for them to the point of handing them a crown. And we did that out of what you mentioned, which was the old who's pointing fingers at who. You could do the perfect implant, perfect depth, perfect everything, and then someone puts on something that has a contour that makes absolutely no sense.
Yeah.
Right? So we are very open with them. We actually have a Colombian dentist who can't practice here, and she worked actually for Nobel for years as a sales rep, and now she works us full time, and she's kind of like our concierge. She goes to like almost like a rep would if you were uncertain. She goes with every piece of armamentarium that you can need to these dentist offices for every insertion, and it's for quality control. And it really, now we have some dentists who they know what they're doing, they don't need that, don't want it, whatever.
Right.
But it's a service that we offer because, and really, it's just we want to protect our work. Like it's like it's
insurance plan,
and they love it, and they send to us because they feel this security, like the security blanket. So it's a great thing. But yeah.
Okay, when the screw becomes loose on a temporary restoration, how do you manage it? Do you just tighten it? I'm sure it depends on the timing of the integration process. Yeah, you're exactly right. So, you know, if you're in that first 2 weeks, let's say, you're losing, how do I do it so that it's the right way? You're losing you're losing the primary stability, and you're going towards more of biological stability. So yeah, you have to be careful on that. I don't know if I really have an answer. It depends on which part of the process you're in.
So I would go back to, so it's a funny thing. Evidence-based, scientifically based, everyone knows that curve that you were just showing, and it's a great question. But I can just tell you that because we can't leave the temps loose, like we tighten them like every time, right? So it doesn't matter if it's 5 days later or a week later. Same thing if a healing abutment pops off in like a typical case, right? Like you don't usually look at what day it is. I say it has to just go back on.
Yeah.
We typically, both of our temporaries and our healing abutments and stuff, we typically do to hand tightness, like so-called 10 centimeter sort of situation.
Right.
Yeah. So
yeah, and I think that's probably the difference too, is none of these are being torqued necessarily.
Cranked down, exactly.
Yeah.
Yeah. Yeah, and in fact, we'll even have, like for some full arches or other things, we'll put notes on certain cases where if we felt we kind of pushed the limits, it didn't go into the high torque, we didn't think it made sense, we'll put a note that to ourselves, don't torque it as tight, wait longer, this one doesn't get loaded for 4 months, etc., things like that.
Right.
So it's case by case.
What are, going into our perio discussion, what are new techniques that you've brought in, you know, in the last year or two? Something that you weren't doing a few years ago that you are now? Implant
related or just periodontal, pure periodontal?
Either one.
Yeah. So I would say pure periodontal wise, my practice is probably about 50% implants, maybe 60% implants, 40% perio. And when I say perio, sadly or not sadly, it's really largely, I don't want to say cosmetic, but it's perioplastics, like gingival augmentation, crown lengthening, aesthetic crown lengthening. Like I don't know the days of so-called, you know, I'm not doing a million flap debridements all day. That's just not, it's a small portion of my practice, not that I don't value it. So one of the things that actually I somewhat picked up maybe from Instagram, as scary as that sounds, or at least reinvigorated, I got very little training during my residency on tunneling. for doing
Okay.
that. I think.
Yeah.
I just
Because it's
didn't.
relatively a newer procedure, relatively kind of a
Yeah,
trendy procedure now.
very. And
Yeah.
and so that's something that I I didn't naysay it, but I was pretty good at what I did. And sometimes you
Mm-hmm.
get caught in that comfort zone of like, it's scary to reinstitute things that you didn't learn under the umbrella of an
Yeah.
educational system.
Right.
So I have been trying, and I admittedly, like when I post my tunneling cases, oh, Mohammed's asking about alloderm. I can give a whole rant on that.
Okay.
I wish I did, but so tunneling is probably the thing that I'm pushing myself the most because I see the benefits of it. Like it's
Yeah.
less invasive. It's nice from a patient marketing standpoint.
Sure.
You know, post-operatively when they heal well early, like
Yep.
people come back 2 weeks later, it looks like you did nothing.
Yeah.
You don't futz around with the papilla, which is
Yep.
huge when you're working in these. So I've kind of started doing it very heavily in the maxillary aesthetics, zone is
Yeah.
kind of like my driving area for tunneling.
Yep.
That's the big one. So with regard to alloderm, it's like, I don't want to say it's like the angst of my being, but it's the bane of my existence or whatever. But I got burnt early in my career a number of times, whether I wasn't doing it properly or what it was. And it's not because I'm the periodontist who's like, don't try it. What? Oh, Israel's talking shit here. I wish I was wearing a hockey referee shirt with this wallpaper. I would just blend in with the background.
I need wallpaper like my shirt too.
Yeah.
I need wallpaper that looks like my shirt.
Yeah. Well, if Israel Implants DC would comment, he does much better than I do with allograft soft tissues.
Yeah.
I would love to get back to them because, again, I see from a patient-centered standpoint, which I'm always thinking about,
Mm-hmm.
that from a case acceptance, from doing multiple teeth all together, I would love to be able to do it. I have dabbled with the idea of going down to Texas to Pat Allen's course. Because if there's one guy I learned from, it would be him. And he was in our in Toronto lecturing to our group of periodontists. And I had a really meaningful conversation, which I actually posted on my feed a long time ago because he swears by it. And I was like, I said to him, like, I trust you. Like, you seem like a good guy, but I'm so confused how we have 150 periodontists here who are all pretty good. And everyone seems to have had a bad experience and you have a good experience. So like, Are you bullshitting us? Where's the secret sauce? And he just felt that it was truly, it's an experiential thing. And it's a practice makes perfect. And it's I guess, I know cut corners kind of thing, but.
Have you used it for vertical tissue thickness?
So, so things like that, like under a Pontic and things like that, I think it's like, and I like, Thomas, when I saw him speaking most recently in Boston at the Quintessence meeting,
mm-hmm.
he said and jokes because he's like, tries to, do the humble card, like I'm not a surgeon. So this is a nice thing for me because he believes in tissue thickness around implants for crustal bone levels, as you do. And so he said, using something like an alloderm or any type of dermal matrix.
Have you used Fiber Guide?
So I just used Fiber Guide for the very first time.
Okay. And has it healed yet, or have you gotten to evaluate it?
It was pre-COVID, so I actually haven't seen the post-op, but I used it in a way. I think we all have a tendency to do this with. Like we test these materials, we tiptoe into it. So we kind of use it in a situation that probably barely needs it to begin with, right? Yeah. And I used it, it was still an aesthetic case, like a central incisor, maxillary, immediate implant. It's actually one of my most recent posts. It's actually a post, not just a story. But I basically just stuffed it in like bone implant void. I put a hard tissue material. Okay. And then right at the so-called critical zone, I used it as opposed to using a CTG, even though it was a relatively...
Oh, I remember this actually. Yeah, I remember you posted that. Mm-hmm.
That's the first time I've touched it. My rep from Geishlick was kind of tossed it to me and said, give it a whirl, see what you think. I'd love to see it work in that capacity. I'm talking about the last immediate implant, Mohammed. I don't know. It was done literally 2 weeks ago Thursday, so I haven't seen the post-op. I've been doing all my post-ops via email and telephone calls, just saying you can start brushing now, right? So I haven't seen it. I'm dying to see it. Yeah. Nice.
Yeah, I've had good experience with it for vertical. Like, I'm mostly using it for posterior. Vertical tissue thickness.
Are you just when you do that? Because this is so kind of putting a hole in it, putting the healing abutment through it type thing, poncho style, and then just closing up over top? Or what's the way you're doing
No,
it?
I'm usually doing like a true two-stage approach. So
Okay.
when the implant is being placed, doing
Yep.
full thickness release with cutting the my brain's not working right now. Releasing the tissue
Yep.
and placing a full
Got it. You're
like
draping it
square
right over.
over the ridge,
Yep.
and then getting primary stability, so that when we go in for uncovery, we're usually placing you know, a one abutment one time kind of abutment on that,
Yep.
and I go in with tissue thickness.
Interesting. Have you
Yeah.
tried any cases like with what I mentioned where you kind of just like so you could put the healing abutment on simultaneously? You don't think it would work as well?
I have, and I haven't had as good of experience.
Yeah.
You know, they do recommend getting primary closure on that, and I kind of tried to push the limit, and I didn't get as much tissue thickness as I would have liked, but I've seen other people do that. So
Israel's asking
Yeah.
all 6 mm thickness.
no, you can cut it. We cut it.
The fiber guide?
Yeah.
I didn't realize it comes in different thicknesses.
No, it all comes in one thickness, but you cut it.
Okay. Yeah.
Yeah.
So I asked them. They said I could just stuff it in there.
Yeah.
Israel, maybe you can speak to this as well, and Kyle, if you've had more experience. So, does it increase? I didn't really feel. I just put it in and put the temp on to kind of secure it. I didn't use any sutures or anything like that, like I would with autogenous.
Yeah.
Does it change? Like in terms of its like, does it become more voluminous, so to speak, with blood or hydration?
Just a little bit, but then it also can kind of smash down too. So I don't really think about it, the thickness as much. I get the thickness that I want, which, you know, is usually 2-3 millimeters, and then place it over the ridge, get primary stability primary closure, and then wait.
And using that, or you're using for that same indication, Alloderm, any other products, or
either one? Yeah, I don't use Alloderm as much anymore because of the fibro guide.
Yeah.
And sometimes I'll feel good about it if they have a.
Is that a results thing, or a handling thing, or a cost thing, or what's the relationship thing with industry there? What's the reason?
I think it's a cost thing. It's also, I've had patients that are fine with fiber guide that don't want someone else's tissue in them.
Yeah.
It's funny how people are okay with animal products, but not with other humans, you know? Everybody has their own thing, you know? It's like some people come in and they're like, definitely not animals. And other people are like, definitely not humans. You know, and I have some patients that will say, you can never take it from somewhere else. And some of my patients are like, I want you to take it from my own body, you know? So it all kind of depends. Yeah, everybody's a little bit different. So we've got about 20 minutes. Actually, we can go as long as we want, but I think it cuts us off at an hour, but then we could just start another one. Let's see, we've talked about provisionals, we've talked about perio, we've talked about, let's talk about pressure.
Sure. I mean, I think of myself, like, I'm certainly not like a stress-free dude by any means. Like, I go through wax and wanes. Like, I can, in the moment, surgically and things like that is probably where I'm at my best. Interpersonally and in my own life is where maybe sometimes I'm more stressed out, you know, I'm dealing with family and other things like that. But I think pressure wise, I just think there's a huge, and I'm sure in you know, where you practice in Beverly Hills of all places, there's, I think just unfortunately, and I see a lot of older dentists telling me they feel kind of sad for me that I'm practicing in this day and age. The type of patient has really morphed.
True.
They're just so demanding. What's Muhammad asking? Dr. Stanley, have you shifted completely to pie base?
Oh yeah.
He's gonna ask all the good questions, this dude.
Let's ask it. No gold whatsoever, because we know that we can't get hemidesmosomal attachment to gold. So when you have a gold abutment, all you have is a pocket on that, and much more likely to lose bone, don't have the stability, don't have the epithelial attachment. So I haven't used gold probably in 8 years. All tie base for me. Everything is a tie base. Yeah. Good question. Yeah, you know, you brought up a point about like
Patients are
practicing
the
at this?
source. Patients are the source of my practicing pressure. Their unrealistic
Yeah.
expectations, trying to manage those expectations, you know, threats like litigious type things. Like these are the even when I truly believe I'm a, like sometimes I'll say to a patient who looks like they're heading in that direction, I'm like, not as a dentist, as a human. Like,
being.
I'm telling you, I'm a human being. Like I'm telling you, I'm a nice, like trustworthy human being. Like
Yeah.
I'm trying to do my best. I know there are other people out there that don't do that, but it's not the case, you know?
Yeah.
What university has me done was on attachment discovered. What is this? Alex Trebek over here, Israel. I'm gonna guess that it must have been where he practiced in Cal. He learned under Joe Kahn at
Oh, okay.
Loma Linda.
Yeah. Yeah.
No one cares, Israel. No one cares that
Joe's
you went to Loma
amazing.
Linda.
Will you guys immediate place an implant if the extracted molar had a PA lesion, septum intact, plenty of bone? Yes, I will.
Yeah, so it's so funny when people put those polls up. Uh, like, would you immediate place in this and this and this? Everyone wants this answer, the strict criteria. It's always case by case, and and people always say to me, they're like, okay, so you immediately place. They're like, but you don't immediately place when there's infection or when it's this or when it's this. I said, well, if you're not placing when there's infection and when there's this and when there's this, then you're not actually
placing
immediate placement.
Yeah.
Like it's like, right? Like when we say we do it a lot, we do it in the face of a lot of these things. And yes, they may be sometimes our demise, but I had one of my attendings in Boston, Mark Nevins, like the Nevins brothers are pretty big, married on us. So the son, he would always say, if there's an infection and I cure it thoroughly, then there isn't an infection anymore. And like it's so, I don't know, it just kind of stuck with me. But if you can access it and you can clean it out and debride it, then putting the implant in spite of a PA, what's the difference between that and putting a graft in? Maybe it's higher stakes, I suppose, but you're going under the premise that you're trying to curette it. And a lot of times I spend probably more time curetting than removing the tooth because of that.
It's totally true. Totally true. Yeah. Oftentimes it's like that. I feel like oftentimes and I always kind of make the joke when I'm doing it with the patient, like, oh, it took longer to clean the tooth out than to take the tooth out, you know?
100%.
And I also give the patients the option, you know, and tell them like, I'm going to try to place the implant and there was an infection here, or, you know, it may not be stable, but let's say the implant fails. We're exactly at the same point that we were going to be at anyways, right?
And so it's funny. I agree with you. I take the exact same stance. I think that's something else that comes with our generation of doctor or dentist. And I put that out to the patient, which is, what are your criteria when you choose the height of a tie base? Why don't you answer that, Kyle?
Usually, I like to have the tie base kind of as short as possible if it's not going to ruin the emergence profile is the answer, because I want to have as much polished zirconia available because we know it's better for the tissues than the titanium is. So as short as possible, unless it's going to ruin the emergence profile. So, you know, usually that means about a 2 millimeter is most of the time what it is.
Isn't it beneficial to use I thought it was beneficial to potentially use a taller tie base to like move even further away from the kind of micro gap or something like that.
So there's Thomas is doing some research on it right now. It's not fully finished yet, so we'll have the real like clinical research based answer on that very soon. Yeah. But you have that gap, but it's done outside of the mouth, and so it's not, you're not worried about that. It's polished down. There's no excess there. So it's more about making as much polished zirconia available as it is. What's the next question? I'm comfortable placing immediates when it's a chronic infection. However, how about an active infection with pus or suppuration? Would you still immediately place a graft?
I personally do. So again, you're looking at someone, and I don't want to say it like from a cavalier standpoint, like that's not the case. I take it seriously, but actually a lot of our patients, we have what we call same day patients. Like a patient will show up, they've called us in advance, or the referring doctor has, that an abscess has just broken out, something has just happened, a draining fistula, they're in pain, they fractured the tooth, whatever it is. We'll try and do the implant that same day for them and to give them the tooth the same day. Again, that said, if the whole buccal plate is demolished, if you know, there's different things that come with it. So I think if anything, a chronic lesion probably has more possibility of having more loss of bone, bigger issues than something that's acute. The earlier we can get to things, I think the better. So again, I know we all want, and I talk about this when I lecture, like everyone says, would you do this? Would you do this?
What's the recipe?
What's the recipe? No, I was joking. Obviously we have sons around the same age, and maybe a handful of months ago we were reading Green Eggs and Ham from like Dr. Seuss, and it's like I would not, could not, whatever. So I kind of put that, I integrated into when I recently lectured. I said, everyone's asking me. I was like, when I didn't place immediate so much, I was like, I wouldn't do it in this. I wouldn't do it in the that. Now I'm like, when I place, I'm like the guy who just tries the eggs and I'm into it. I'm like, I would do it in the molar. I would do it in the septum. I would do it with infection. I would do it with, like, I don't know.
Yeah, it's true. And I think, the longer we practice, the more we kind of push the limits. And I think that's important for younger doctors too, that when they get out there, I always say you have to push your limits in order to learn. But don't push your limits to something that'll get you in trouble. You have to slowly get there.
It's a fine balance.
Yeah, once you've done, whether you're a specialist or whether you're a general dentist and you're placing implants, once you've done, 50 for posterior non-aesthetic first molars, that's the time to then start to go for a premolar. Once you've done enough premolars, then you go for anteriors, and you don't just start out by going with these anteriors.
Yeah, and unfortunately, I agree. That's where, honestly, if I catch a whiff of something, and we've all been there, where you find yourself in over your head, even if you had like the capability and you just want to cry, you're like in the chair and you're doing it. You wish you had, like, you're attending or whatever. And you think to yourself, I would pay anything, forget how much they're paying me, to not have this case weighing on me, like to be in this moment where I'm sweating like this. Like, I wish I wasn't here. I always think about that. And like, that's why I'm like so much more selective now. If there's even an inkling that something will be challenging to me, not that I don't challenge myself, like I do, but I think it's like something that I send it to the oral surgeon. I have periodontists in Toronto, guys that actually, some that I met on Instagram who I do it. I send them cases. Like, they're better at vertical ridge augmentation. I don't do vertical ridge augmentation well. The patients are confused almost. I thought you're the guy I'm supposed to see.
Right.
Well, yes, for this, but for this, you're going to go see this guy.
Yep.
Phil, after you use your temp shell and bond to the temp cylinder extraorally, how are you determining how to contour the facial gingival zenith / how to contour of the temp crown? So it's a fantastic question. And this is, again, my lab who literally is staring into the socket. So there's no impression or anything to capture that, but it's basically being done by eye. And they're pretty much linking where the neck of the temp shell ends to where the collar of the implant or the temp coping begins, right? And they're trying to create that nice emergence profile. And, some people slightly under contour that so-called critical and subcritical areas. Some people over contour it. It depends if you want to get we tend to under contour. I'd always rather the gums move apically.
Right, and push them back up if you need to. Yeah,
exactly. I can always create like a bulge and then push it up at a later stage. You want that more tissue thing. So but it's done by eye. We'll put it in if we feel it's pushing too much, or if it's hitting interproximally at the bone or whatever, it just goes back and then it gets polished a little further, adjusted, and then put back in. So it can be a bit of a guess and test is the way that we do it.
Yeah, I often do a lot of it digital, so I'll pre-plan a lot of it based on how deep I'm placing the implant, where the gingival margin is, so that I can kind of have the provisional almost done, which is one of the benefits of the digital workflow on doing this.
So how do you do it digitally, Kyle? Because that's one thing, and this isn't me this is me truly asking, not giving you a hard time. So as a guy who does it by hand, I love the idea of having more of it done in advance and planning, but oftentimes we are making changes peri-surgically, right? Like, I may decide to place an implant and then I need to swap out that implant slightly wider, slightly longer, slightly, different. The bone pushes it slightly buccally, whatever it may be. And even timing of an implant, for instance, where you're saying you put it to a certain depth. If you have the temp somewhat made in advance, so you're just going to do an extra couple of torque rotations to then get it to the position, or how does that all work?
Yeah. So kind of two answers there. So first, on the timing, If
Yeah.
I'm going directly to the implant, where oftentimes I'm not anymore, oftentimes I have a stay-in abutment, whether it's on one from Nobel or whether it's Connect from MIS or something like that.
Yeah.
That normalizes that so that I can place that and then do a non-engaging on top of that.
So the thing can physically rotate, correct? Yeah,
Yeah.
I've seen that. That's the
Or
key.
I'll do what
You do
you
a
said.
non-engaging so timing doesn't matter.
Yeah, so I have engaging on the implant, which is what's important, biologically.
Yeah.
But then at the tissue level, I have non-engaging
Got
for
it.
the provisional, and then I change it to engaging in the final.
Yeah.
Or like you said, I'll do an extra little rotation, which I don't do as much anymore, but
Not the end of the world if you have to.
I definitely did that before.
Yeah.
So yeah, and the other thing is that I do everything fully guided, even the implant is place guided. So
I would love to.
oftentimes you're talking about
Static?
like pushing a little bit to the buckle doesn't really happen as much.
Static guide, or are you doing any?
I'm doing a static guide,
dynamic?
yeah. So for me, like my idea with navigation is that I'm not good enough to do it with navigation. So so how I think about it is when I'm doing guided surgery, I'm guiding my brain during the planning.
Yep.
And then I'm guiding my hand during the placement, like
Yep.
physically guiding my hand, right? What I like to say with navigation is you can still place the implant in the wrong position. You'll just know it's in the wrong position.
Yeah, I agree. I've only done a couple cases with XNAV. I thought it was really a tremendous technology. I think if I stuck with it, it could be a wicked in between for me.
Yeah, I'm gonna try to use it some more and
it's a lot of setup
get
and it's a
more
lot of learning curve every time.
Yeah.
Like if you don't do it routinely, like anything. So
yeah,
but I was blown away. Like I had done it and I had someone take a video of it because I was crazy. I was showing it to like friends and family. I was very excited after using it because
right.
I felt like I was like from the year 3000, where I was like,
Right.
I was, although medicine is using this on a routine basis,
Yeah, it's normal for them.
laparoscopics and everything, I was doing the whole surgery looking at the screen. Like I
Yeah.
glanced at the patient's mouth, but I was like this when I was drilling. I was like,
Yeah.
this is fucking wild.
Yeah.
Someone asked about taking an X-ray. Do we take a radiograph after seating to modify the margins? So not necessarily to modify the margins, just to make sure it's seated. So a lot of times there may be bone that is kind of in the way. I use a profiler or a mill very commonly. That's an underutilized instrument that I think
Totally.
is an immediate game. Or if you're even placing implants to proper depth subcrestally, you should be using it.
Yeah.
Don't take a handpiece to it because you just risk fucking up the
implant.
The implant.
Yeah.
But yeah, so we take an X-ray at the end, and if it's not seated, then we'll have to take it out and find what is causing the the lapse in insertion.
Yeah. And you bring up a good point about subcrustally placed implants. I've been doing subcrustally placed implants for a long time, and it comes from my work with Sasha Jovanovic. Sasha always made sure that we had 3 to 4 millimeters from the implant placement, the implant neck to the final ideal gingival margin. And oftentimes, as you know, when I'm working with Sasha, we're working on big grafting cases, right? So we're going like big vertical grafting cases where the ridge is like this, flat, and I have to figure out where the gingival margin is. So on those cases, we're oftentimes placing subcrestal.
100%. Like the subcrestal is key. I mean, and you talked about it. Bone is not flat in a proper, healthy, positive architecture situation.
Yeah.
That's why teeth have an undulation in the bone levels, and that's why the papilla follows that, right? So we need to recreate that. I commonly now, if I'm doing a case like, for instance, lateral to lateral, very common, like before you bridge situation, I will take a large round burr that I use for like plowing down the ridge when I do alveoplasty for full arch, and I literally create pontic sites in the bone because it looks like scalloped because I want the pontics to be able to later, not even just with a round burr on the gingiva, but I want it really to be actually like coming out of that tissue so it mimics reality. Yeah.
I was I'll just say it now, but I was creating a post for later about how most congenitally missing laterals are placed too shallow.
100%. Because the bone is like from the altered past eruption next door and stuff. It's always way too high.
So you never have a problem with height in those. It's always width, right? You just don't have the width. And I think the problem is with almost every residency, whether it's perio, oral surgery, pros, anything, my residencies, most people are taught to place an implant. You open the tissue, you place the implant to the top of the bone, and you close the tissue.
And that can work sometimes,
right? If you have thick tissue.
If
Yes.
you have thick tissue
And if you've already lost bone, basically.
Yeah.
Yeah.
Yeah. So no, I agree. It's a huge aspect. So yeah, those and that's why so many, if you see those laterals, they look like little
Short.
stumpy things because, and guess what? And you know what? I've had tons of second opinions where patients had them placed recently and they come in, they're like, it's so short. What can you do? And you know what the crazy thing is? There's only one thing you can do, and that's to remove the entire fixture.
Remove the implant.
You cannot do crown lengthening on an implant and show the threads of the implant. So unless that person somehow did place it decently deep, but there was a problem with the prosthetic or the tissue thickness, you have to start from scratch.
Yeah.
It's a disaster. And I can tell you, I've seen too many of those cases.
Yeah.
It's a very common instance. I guess this is like, it's the more you know, the less you know sort of thing.
Yeah.
It's like these intricacies that we're talking about that we're like, oh yes, of course I know exactly what you're talking about. That only comes from fucking up and from like time, right? Like it's like,
yeah, well, I think a lot of that too comes from the like surgical aspect of our community thinking only surgically, and the restorative aspect thinking only restoratively. So, you know, the cases that I've seen, like I had a case that came when I was working at my dad's office, came directly to me. This oral surgeon had already placed the implant, so shallow. And when you think about it, I think the patient came directly to them, so the surgeon didn't have any restorative input. And as you know, like anyone who does surgery, when we get in there, we're thinking about surgery, right?
Oh yeah, of course.
And that's why I like when I use the digital workflow, is that I've done all of my restorative thinking when I do the planning, so that when I'm in surgery, all I'm thinking about is surgery. I don't have to think, is this in the right position for the tooth? I already thought about that.
Yeah.
And I think the problem that we have is that, you know, like in that case, I'm sure the surgeon went in, they opened the flap, they said, okay, do I have enough bone? You know, how's my stability? Great. But the restorative side wasn't there that day.
I'm a GP. Where do you recommend to get implant CE? There are so many options.
There are.
I mean, you know what? You mentioned Sasha.
Yeah.
I'm certainly not in bed with him to any degree, so I'm an unbiased source. But there are a lot of things out there.
Yeah,
I think that Guide is a pretty well known and decent one, to be totally frank. Otherwise, I think it is beyond overwhelming. I think even if you can find surgeons that you may refer to or know, to start off just shadowing them if they're willing to be kind enough to do that. I know that I've learned a ton from doing that through my career. I think that's a huge piece, like seeing things live in action. And then otherwise, even through a reputable implant company, usually the reps should be able to direct you in a decent place. Where if you're working with one of the bigger types of implant companies, they'll have a person or a reputable kind of person in that sector that is a good starting point. And the challenge is that it's expensive to get started, right? I mean, a lot of these courses are $25,000, $15,000 for these so-called mini residencies, right? You kind of use that. Oh, David Attia. Do you know David? Do you know David? Do you know him at all? Yeah, he's the man. He's awesome.
I think from a CE perspective, I would say look for speakers who are doing research as well. I think that's kind of important in that case. When like you're talking about Sasha, you know, like Sasha's done decades of research and bone regeneration. You look at people like Joseph Kahn.
I love Joe. I mean, I haven't met Sasha personally, so I don't know. But so Joe is another guy too. But Joe does specific, kind of intricate lectures and concepts. He's not like a guy you're going to do like a thing besides going to program. The truth is, and I'm not I think, I mean, the other option is if you think you're really interested in implant dentistry, you could do like an implant fellowship, or you could do like a periodontal residency or something along those lines. I mean, I don't want to be telling you have to take 3 years out of your life, but if you think you're potentially passionate about it, that's a great start.
Yeah. And I would say if you're a GP, do a course that focuses on learning from the restorative aspect too. Not like one of these cases, like, let's go in and place 20 implants in a weekend, because you don't really learn anything from that.
Look, I think mastering the restorative side will make you make the surgical side so much easier and better.
Yeah.
I was like just ish fortunate that it was just starting to become a thing. This whole prosthetically driven, guided, whatever
Yeah.
you want to call it. But I
To get comfortable with doing traditional, like basic surgery.
okay.
So like,
We're back.
okay,
Sorry,
so I was saying, if you're a general dentist, I see so many general dentists that are going in wanting to learn implants, and they don't know how to
we
do a
got the
flap.
we got the honest periodontist in the house too.
All right. But knowing like, if you're planning on doing implants, you should be able to do like a impacted wisdom tooth. You should be able to do a surgical extraction. You know,
Yeah.
these are like basic surgical principles, how to hold a suture, how to hold needles.
Philly.
Going in and saying, I'm going to learn surgery all in one weekend, I don't think is the best way to do it. So
I think the best way is to go to residency. That's not trying to sound like an asshole.
Yeah.
But
yeah, I mean, I did a year of residency because I wanted to learn kind of the perio pros thing, but that exists in Brazil, doesn't really exist here.
yeah,
I got kind of lucky.
Yeah,
people are coming back to us. Okay, good. Very well said, actually, especially with respect to the basic surgical principles and restorative aspects. Yeah, I think I've seen people that, and people ask me this, they'll say, you know, I went and I did this course in Dominican Republic or in Mexico. I placed 20 implants and I still know nothing. And I think so much of that is that you don't know why you're placing the implant in that position. You don't know what's important about it. You just know, yeah, I placed the implant. And I don't think that's the answer. Oh, here we go. So you have 2 implants placed 4 months ago, but on loading day, one has not integrated and has palatal recession. Would you place another one instead or graft and wait? I think it just depends.
Yeah. So, I mean, listen, that sounds like a very specific kind of circumstance.
Yeah, that patient is on the phone with them right now, right?
And oh, look, this guy from Portugal is awesome, Yo Gaspar. I think that if one of the implants is shot, you're finished. I mean, when an implant's not integrated 4 months later, that's called a failed implant.
Yeah.
In my books.
But I think what they're asking is, would you place an implant the same day, or would you graft it when you find out it's failed?
It depends. So it becomes the same circumstance as an immediate situation with an implant. So I try and take it out. And so we're going to get some awesome comments from Honest Perio. Honest Perio, we are depending on you for some good spitballing over here. Wait, let me scroll back down. The fact that you went to Dominican to learn how to place implants alone tells me that you're you killed me. I love it. And he wrote one.
Oh, Richard Martin is on. Hold on. I got to give a shout out to Richard Martin. For those of you that don't know who Richard Martin is, he is like one of the kings of partial extraction therapy in the US now.
So I've never done that. I mean, I'm curious about it. I don't judge it.
Okay.
I think it seems very technique sensitive to me, which a lot of people underestimate and think, oh, I just like leave a portion of the fucking tooth in there and then that's it.
Right.
I think that's where you run into trouble.
You're definitely right. And I learned this kind of remotely from Richard and from Howie in South Africa. And it definitely has a learning curve. I was talking about it, I think yesterday, or I've done so many lives recently, I get them mixed up. But I
Nobel rep Trish is on here. I gotta say.
I did my shield too thick. I did my shield too thin. I had shields that came loose where I had complications. But I tell you, when you do it right and it works, it is amazing. Like, you lose nothing.
So tell
it's crazy.
Me this, because I'm all, as you know, I'm like progressive. I'm all for advancement. I like to step lightly into things, but it's sometimes I have like the old, if it's not broke, why fix it kind of thing. So it's like, if I've gotten pretty good, consistent results, just grafting in the void and maybe the odd time throwing a little soft tissue in there. Does this offer really any greater benefit? I guess technically you avoid the use of materials potentially, and you know, maybe if you get really good at doing it, then you don't need to harvest any soft tissue or graft the area or whatever. So there may be that element, but
Yeah,
otherwise it's
I
like,
think that's it.
yeah,
Aesthetic wise, I think that it's some of the best aesthetics I've seen.
yeah.
You know,
It
unless
makes
you're Iñaki Gambarina. But
biological. Yeah. So I'm familiar with him, and he's a guy I've never seen speak. He's a guy I didn't know about until I came on Instagram.
oh,
And
okay,
there's kind of like Insta famous people, and there's like real famous people also on Instagram. But now it's kind of
right,
all becoming kind of one.
yeah,
But
right,
he is like. There's guys I think you can tell with a trained eye who's kind of what.
yeah,
He is a guy. I mean, his work is next level. I was like, how did I not know who this guy is? He's
yeah.
absurdly talented.
Yeah,
Yeah.
I think for me, he's such a role model because he does periopros.
You meet
You know,
him. Is he a prosthodontist, a periodontist, a GP? What's his
he's
training?
a prosthodontist by training. He trained at Washington with like Riccardo Mitrani,
Yeah.
and
Yeah.
there was like a group of them that were all together at one
Yeah.
time. I forget who else it is, but
Yeah.
yeah, I think
Ricardo's awesome as well. I mean,
yeah.
him and Goldberg in Mexico are fantastic.
Oh yeah.
But did you meet him through Nobel? Like, I was actually excited to. He was going to be at the symposium in Vegas. Which
Yeah,
I would have
Nobel
been
and through
sharing
Seattle
it,
Study Club.
drinking. Yeah.
Yeah.
I really wanted to see him because his stuff is, when you talk about top.
Yeah. Yeah. If you're losing a tooth, you're flying to San Sebastian, Spain, and going through the whole thing.
He's next level. There's no doubt about it. But does he do partial extraction therapy routinely?
I don't think he does because
No,
he's so tissue based, you know.
he's
And that
very
brings up a good
tissue-based.
point, like what you're saying. And I think what you're saying is like, do you need partial extraction therapy if you're doing everything else? And the answer is no. Are there advantages to it? Yes. Some of the
Yep.
advantages, like you said, you know, less grafting material, you don't have another surgical site, all of that. So yeah, but as far as I think in the US, the person that I can think of the most that's done probably the most of these and helped on the research is Richard Martin in Dallas. He's an oral
Yeah.
surgeon. And what's awesome about Richard is he's an oral surgeon, but he has read Pascal Magne's book. He's read, you know, like prosthetic books. He knows, although he doesn't do the prosthetics, he understands all of it and helps out his referrals. He's really kind of I wish he was in LA or, you know, somewhere closer so I could utilize him more. I think one of the greatest indications for PET is side by side implants. Yeah, I think you're right. Having partial extraction therapy side by side. But then, you know, it's the same thing. You see Inyaki's cases where it's side by side,
Yeah.
and you say,
So,
okay,
and
yeah,
again, I just recently did a webinar on Blake McClellan's thing, Implant Compare. But one of my big areas, Todd showed,
Schoenbaum.
I love Schoenbaum.
Yeah.
Speaks a lot about it. We talk about the same stuff, like we use the same research, evidence based, but it's one of the trickiest things, partial edentulosum and adjacent implants. But anything you can do. But the only thing that I would say about why I don't think there's partial extraction therapy to me, in spite of what my boy Phil, his name is also Phil. I don't know if you know Fresh Prince of Perio, Phil Fava. He wrote exactly.
Oh yeah, of course.
PET stands for leave a portion of the fucking tooth in there.
Yeah. I'm speaking at his study club in a few months.
He's awesome. So, but I think that, and correct me if I'm wrong, that I think that the majority of the time, it's for keeping the buccal aspect.
Right.
Whereas I think the challenges with adjacent implants more come with the interproximal.
Keeping the interproximal, right?
So that's where narrower implants, spacing them apart, everything from the zero bone loss concept standpoint really become proper depth of placement becomes extremely critical. I don't know if PET, and again, I'm not experienced with it. I don't know if PET would be that.
Oh yeah, Richard was saying he always sends me a lot of his PET cases because he's been my like remote PET mentor. So he's always showing me cases and I send him stuff. So
yeah.
Oh, my friend from Brazil, one of the top orthodontic surgeons from Brazil is on. Wow. Nice. Hey man, how's it going?
And honest Perio was asking me why I can't keep a straight face because you're hilarious, dude. What can I say? I want that to be like some professional thing that's going on here. We're just having a casual chat.
Yeah,
so it's all good.
You know, here's a question that I just recently read in Inyaki's new article, is that he places his graft material before he places his implant in an immediate placement. Have you done that before?
I have, and I know people that do it.
I have done it before. Yeah.
I personally don't really think it's necessary,
Mm-hmm.
mainly because when I think about extraction socket healing, the
Yep.
part that I'm least concerned about filling with bone is the apical portion, because
Mm-hmm.
that is the first part that, like, think about when you see an extraction socket healing a month later, it's like half of it's filled in, right?
Right.
So I see guys using probes to make sure they get particles of bone all the way down. I
Yep.
actually don't care that much. So I think
Mm-hmm.
that's part of the reason he does it. Is there the only other reason, which is not great to rely on always? I have done that in cases where I didn't get great stability as
That's when I've used it before too, is like that.
a crazy rescue tool. But
Yes.
that's not great either. That's like when you got a spinner and then you're like, shit, I need to do something, and you
Yeah.
just kind of coat the edges. But otherwise,
I can think of a case where this was before I stopped promising patients things, but I kind of promised the patient that, oh yeah, we're going to place an implant immediately. I'm going to put a provisional on it the same day. And then I put it in and it's like spinning. I'm going, what am I going to, I like zero, nothing, like wiggling. So I packed it with bone, put the implant in and got like 10. And it was
yeah,
one of these ones where I do I push the limit? Do I not? And I ended up not provisionalizing it. The patient wasn't happy about it, but she was cool, and it ended up working out.
yeah, no, I'm not like the under promise over deliver, but
Yeah.
again, and this is maybe just a maturity thing because again we're around the same
Hmm.
vintage, but I used to be like implants, greatest thing since sliced
Same.
bread,
Yeah.
gonna do it, success, etc. We're gonna do this, take this tooth out, put it in, put a tooth on. Now, I'm a big fan of. I always lay out. There's two ways we place implants: the traditional way, the other way. If everything goes well, we'll put the everything.
Yeah. Honest pair, it's because you're not a surgeon, Kyle. Stick to the runway.
He's fucking hilarious. Is this true primary stability, though? True primary stability, though, or just compression leading to mechanical stability as an immediate standpoint? Any concerns? I think that's a concern whether you do it with the bone, with anything. So there's ones where, especially I've been placing, so Straumann BLX, this is like
Yeah.
a new endeavor for me. Very aggressive threaded implant, somewhat similar but different to Noble Active. But
Yeah.
that's where I think I often joke that Nobel Active was almost sometimes too good at getting stability, because it may actually, like, you may just be able to get the stability with like 3 millimeters of it in the apex of
Yeah.
something, and
Yeah.
then it's not true. It's mechanical, and with time,
Yeah. You lose it over time.
Yeah,
Yeah. Implant compare. I'm just here for the hair tips.
I know.
Don't take any from me right now. This is like I'm going for the homeless look. So
I love it. I know I'm gonna be back. I was sort of a short hair guy when I saw Blake in person in Scottsdale for DIA. I was kind of rocking like that, cut on the side and whatever
Yeah.
you got to do. And you had that for a while. I was trying to be you as well.
Oh, well,
And
thank you.
Now I don't have it. Now it's just gonna start getting long. There's nothing else to do.
Yeah.
Freshman to
How?
perio.
By the
Phil
way, how are
Fabio's
you
got great
liking?
locks.
How are you
Yeah.
liking BLX?
That's a tough question. It's been a learning curve. I think a lot of people. So for me, the reason we in part switched to BLX and got the chance was we were a big Nobel practice.
Yeah.
For reasons nothing to do with the function of the implant or the product. Straumann had kind of been courting us for a period of time. We switched over to them. I'm not the owner of the practice. I'm just an underling.
Yeah.
But it's called a ducktail, Phil. It's not. Is it what's it called? Short in the front, long in the back, a mullet.
Mullet.
Yeah. So in terms of BLX, we were kind of the pre-launch in Canada. So it was being used in Europe, but us and one other company in Canada actually, or even in North America, as far as I know, and Honest Perio, we weren't getting them for free. It's a crazy expensive implant, I think, is one of their challenges. Oh yeah, fine. Honest Perio's on. Honest Perio, when I go on for any live, you better be there, man. You're like the color. So with BLX,
so only one restorative platform, right?
Yes and no. They have what's called RB and WB. RB is RB goes all the way from. So one of the crazy parts of this implant is it has so many diameters that it's almost confusing. So it goes 3.5, 3.75, 4.0, 4.5, 50556065. So it's like you're almost like fucking confused when you go like
Right,
tell
right,
your
right.
assistant what to get. You're like,
Yeah.
just give me 3 options. Like,
Right.
I don't know, like what's the, you know, and to make matters worse, each of them are different in terms of their design. Some are slightly tapered, different blades, different cutting edges, pitch, etc. So that's one thing. But the up to 4.5 millimeters, I believe. So all of them can be RB. You
Okay.
can do all of them with RB, but when you get to 5 and over, you can do RB or WB. So you can
interesting.
change the way that it comes off. So, you know, how good is that utility? Maybe from a restorative referral standpoint, it's kind of sleek because it's like simplistic. But
Yeah.
the only thing is that I don't think it confers a great advantage beyond that, to be honest. Yeah.
Okay. Yeah. So do you think about it like if you're placing a really wide implant, or let's say you're placing the one that you can't do the wide one on, the biggest one that you can't do the wide one on, you have to place it deeper so that they can get to a wider emergence profile.
Yeah, so it's a pretty aggressive platform shift in that implant. And so you have to take that into consideration 100%. So Phil's saying they can be restored with a platform shift, all internal, yes. Then they can be restored on the shoulder. That part is weird. So yeah, so it's either a full platform shift or you become, if you want to use one of the WB ones, that's WB or RB, yes, it sits on the thing. There's a lot of other intricacies which make it, at least like any system, challenging to begin with. I feel like Honest Perio is low key Howard Ferran, just rolling people under an alias. But
my whole house is 60s feel. So yeah,
you're all mid-century,
not just this part of it. Yeah.
So, but anyways, it's a good implant. It's a little challenging and softer bone to get stability with than I thought it was going to be perfectly honest. And I actually recently just had a conference call with Ophir Fromovich, who I think you may be familiar with. He's the inventor of Active, went over to BLX because we were struggling with certain aspects of it. And he's done more than anyone. He invents it. Great question. So what about, and I love this guy from Portugal. He's incredible. No one does osteodensification with him. He's tried to coach me through it. We've been like DMing forever. So what about osteodensification, Phil? Are you a big fan already? So we're starting to think that this osteodensification or using osteotomes, if you don't want to be as fancy, is maybe a really good adjunct with the BLX, especially in these soft bone situations, because the threads are so aggressive that
it doesn't compress it.
It kind of almost plows the bone. You can't under prepare as much. But anyways, it seems to have this soft or this kind of sweet spot, and so we're learning. We've been placing it for about a year. We've placed about.
They're trolling you so bad. This is so great.
Don't hurt yourself when you pick up that name you just dropped, Phil.
That's great.
Guys, has anyone heard of Matt Fine, like at Fine Odontics before? He has like 30,000 bot followers, but he's really good at grafting. He's awesome. You should check him out if you haven't heard of him. He's really good.
I need to get some bot followers because I don't have enough likes or comments. So yeah, I need to get some bot followers.
Yeah, you know what? These live things are only good with this type of banter. Otherwise, it's just us two idiots just talking about shit that no one cares about.
So are you using osteodensification only for certain indications?
Yeah. So I actually was I was really trying to use it for 2 indications initially. One is that we're on the graft less, and I mean not without grafting, but trying to minimize grafting end of the spectrum, our practice. We still graft, of course, when necessary. You can't do everything without. But I wanted to use it for like thinner ridges was one thought, to kind of like an expansion type of tool or minimize cutting away. And the other is for internal sinus lifts, which
I see you do a lot of those.
Yeah, implants, DC, Israel, Putterman was like beyond crucial. Like he literally held my hand. The guy flew to Toronto. Well, it was like there was some self-servingness to that. Like he came to hang out and like kind of best practices and learn. I hope he got something out of it. But he was like over my shoulder for doing a case, literally, like whispering to me in my ear, and has been kind of the guy. I'm starting to get the feel of it, but now that I haven't been practicing for a few weeks, courtesy of COVID, I'll just go right back to the beginning. So
But do you think for osteodensification that
yeah.
it is a biologic thing or a mechanical thing or both? What is your opinion?
So I had a number of failures with it initially. I
I remember seeing that. Yeah.
later on as perio, we miss you, bro. But I think maybe, I don't know if I wasn't using it properly. The owner actually called me to like ask me,
Uh-huh.
and he wanted me to take the course in Chicago when I was going to. We had some issues, I couldn't go, but I think I've learned a little bit in terms of how to use it. I think that it's not a use like just with ease, like they make it appear, but
Yeah. That's like everything.
yeah, I just wish they had, when they sold the product to me, it was kind of like, here's God's gift, just use it. There's no instruction manual really. And then when I started getting failures, it was like, oh, we really highly endorse that you take a case. Well, I was like, I'd take the course. I was like,
Yeah.
you should have just told me that. Like that this is like, there is a lot of things that come with this. You can't just start drilling away.
Yeah.
Because as a guy who has done a handful of implants, I thought that it would be something just easily incorporated. So there's a learning aspect to it. Who knows?
Yeah.
Yeah. How many Porsches do you have? Let's get down to business now.
I have 2.25.
Yeah, what, the Cayenne or Macan?
Yeah, so I have my 911. My wife has a Cayenne, and then I'm building my 1980 Turbo right now from a shell. I mean, I'm not building it. One of my patients is building it, but yeah, it's in the process.
Yeah,
I'm gonna have to sell all of them in order to pay my mortgage, though. So
true, I'm waiting for that. Let me know. No, I'm always kind of like muttering things to you. I'm not like a so-called Porscheophile, but it is something that I really Phil's asking how many of the Porsches run.
Oh, two
Yeah.
run. Yeah. Two. My 80 doesn't have an engine or a transmission or doors yet.
Yeah. So anyways, yeah. I have long kind of, I've loved them like when I was a kid. I'm not like a huge car guy, but I really would, I would love one. Phil, what do I drive? So I'm not really a huge car guy. My wife drives an X3 and I drive a Jeep, like a Jeep Grand Cherokee. Like,
but you're really looking at classic ones, right?
And this is where you can give me, this is like,
that's where I come in.
Forget like zero bone loss concepts. Let's talk about, so I'm debating a few things. One is the possibility, should I get like the most accessible, cheapest option is like a 996, right?
Yeah.
And they're the least desirable. My father-in-law has one. You buy them for like $25,000, like 100,000 clicks on them. They're beautiful.
It's a lot of car too for not a lot of money.
They're awesome. So I've thought about the possibility of just doing that to like have it. I live in a winter climate here. Who cares if it's a 4? Just use it in the summertime as needed.
Yeah.
That's one possibility. And then, but I don't know if that will not appreciate, but depreciate less, like so many Porsches hold. And then the other option was the possibility of like 993s are my favorite. I would love to get one that has between around 100-ish thousand, something like that. I just don't know.
Should be a lot of those, especially in Canada when you guys aren't driving it 9 months out of the year,
So I would basically, and I just, plunk it in my garage, drive it like not even full time, I think, like during like spring and summer, but as a treat. And then like literally just keep it, let it be a low mileage thing that really holds its value. But I just don't know, because I don't know, that's for me really more definitive Porsche in my head and like what I would love to do. What do you think? But that's going to get me, from Canadian dollars I'm talking, I can spend like 25,000 to get like a 996. To get something like that, I would have to spend like $45,000-$50,000. So it's like totally different beast. But is that maybe a better investment in a way, kind of thing?
I would say don't buy a car for an investment. Just buy a car, whatever makes you happy. So if you like the 993 better, buy that one. But I'd say best bang for your buck is 996 Turbo.
And
if you can get a
people
996
told me those
Turbo,
are going to be like 10 years from now.
Oh yeah, they're already appreciating. So if you can get one now, you'll have a great car, and it'll definitely appreciate. I think they all appreciate over time. It's just like my car is 9 years old. All of a sudden, everybody likes 997.2s, and like they're going up again.
Yeah. So that's my conundrum. But I'm more like the like I'm a keyboard warrior. Like I'm just like constantly looking on Auto
Yeah.
Trader. We don't have Bring a Trailer really here. Like it's like when
Oh,
I'm looking
I'll
at
pray
it.
for you because
Yeah.
I'm on Bring a Trailer every night.
Yeah.
I'm just
So
searching. Well, I'll tell
someone
you that it's a slippery slope
someone asked,
for
oh,
sure.
I guess, Dr. Gaspar asked me, Phil, let me know, let me just ask your opinion about Novabone. So
Nova Bone, yeah.
yeah, and Israel should pop in here as well if you're still hanging around. Do you know about Novabone? Have you kind of seen it in action on
I've
Instagram? It's getting a lot
I've
of hype.
seen it, but I haven't used it.
Yeah, so
Yeah.
I started using it again. If I had like a mentor who kind of taught me for these internal lifts, it was Israel, and he was kind of using it, and he kept saying to me, "I think this is like kind of key-ish. Like it's very helpful as like compatible with it."
Mm-hmm.
So I whether my experience came at the time I started using this, and I just kind of attribute the success, I don't know. The only thing is I've just started using it a few months ago, so I'm curious to know. It looks amazing on a radiograph. It's extremely dense and opaque. It's an alloplast, so it's
Yep.
will it ever turn over? Will it not turn over?
Right.
Will it become bone, histology,
Yep.
etc.? I don't know. Do I necessarily care? People talk about. Actually, Matt Fine said. I think he said one of his instructors said if you put a shoe in a sinus that it would turn into bone. I think I had a guy who said if you put sand in the sinus, same thing. It's so vascular, things turn into bone there. But
Yeah.
do I even care? Because we know short implants kind of work these days. So if I have 6 millimeters of an implant integrated and 4 millimeters is in put ketchup in a sinus, you get bone.
Yep.
Do I care that I have that 3-4 millimeters of it are encapsulated in something? I don't know if it matters at the apex. So, but
Yeah.
Novabone it looks great. It handles well. It seems to be good to the thing. Would I put it in a socket as like a socket preservation? 100% not. Like that just wouldn't be the indication for me. So that's kind of my thoughts on it. I'm curious to see if it shrinks like down the road when I bring people back in for their follow-ups.
Yeah.
But
No,
it's
good.
not good. It's really good. Like you put it in a resin gun essentially, and it's
Yeah.
like prompules, and you basically squirt it up the osteotomy. So it's like very good in that respect. Yeah.
Sounds promising.
Yeah. Who knows?
Great. Oh, Richard Martin says, great for internal lifts
Yeah.
with a piece of PRF. I'll send you some long-term, almost 10-year cases. That's what's so awesome about Rich.
I'd love that.
Yeah.
Send it to me. I'm gonna be following you when we get off this. I'd love to see it because I'm kind of on the the starting end of it. I love jumping under the so-called umbrella of confidence of other experienced clinicians. So
People are saying, yes, it shrinks. Okay, yeah. Well,
and this guy's extremely. He actually lectures extensively for Versa, and he also was coached the hell out of me. A lot of long DMs, patient with me, helping me out, which is a beautiful part of Instagram when it works. But
for sure.
That's the nice.
Yeah, everyone can sit and learn from each other, right?
Yeah. So I mean, I'm sure it will shrink. And again, do I care? Not necessarily. We see people put implants into sinuses and like do a tenting, and like you get some bone or some dieback, who knows? And frankly, let's be honest, we've all put implants and just perforated into the sinus before, and that just works fine too, by the way.
Yeah.
So I mean,
and then I've done cases where I do a beautiful sinus lift, place the implants, take all these pictures because I'm going to show it on all these big podiums, and it fails. The patient gets an infection in their sinus, and you have to graft the whole thing.
Exactly.
Yeah. Yeah, you have these cases where you're like, I'm going to lose my license on this case, and it's perfect, right?
Yep.
Then you have the exact opposite where it's like, this is going to be the best case I've ever done, and it's tanks, and the patient's pissed off, and there's infection, and et cetera, et cetera. So,
nice.
Yeah.
Very cool, dude.
Okay, so anything we need to cover that we haven't talked about? We've had a fun conversation with a lot of friends and trolls, and exactly what an Instagram Live should be.
Exactly, you're right. We encapsulated it all. Anyways, Kyle, it was great catching up with you, man.
Really good talking to you.
Say hi to the family. It's too bad that we are not going to see each other in Vegas. Hopefully, at some point.
I know. I was looking forward to that.
Yeah, and your little guy's doing well. He's like 3 years old now, right?
He's 3. Yeah, he's 3.
My guy's 3.5. I know that they're close in age, and they both have interesting names. Your guy's Valco.
Valco, yep.
Mine's Smith. So we have both screwed up our children. That's great. I love that. So see, this is why we were connected. We knew that there was something more there.
That's true. It's the long hair, the weird names for our kids, and the love for old Porsches.
Very nice. Well, don't be a stranger, buddy. Thanks for having me on, for whatever this was or wasn't. It was just us actually having a conversation as
Yeah.
kind of dental nerds in person.
Yeah.
But I love it. So
Yeah. And
let's,
I'll post this on my feed, and then I'll also put it on my YouTube too, so that it can kind of live forever.
awesome.
So
Happy to chat anytime.
thanks,
Peace
guys.
out, buddy. Yeah.
Bye.
Take care.